So I decided that I would present a paper that I was very, very fortunate to be invited to work on with Dr. Jaswinder Guman, Dr. Hari Guman, as well as Dr. Tom Reichenbacher. And was very excited because this paper was actually published just last month. So I decided that today I would go ahead and present the paper. It's a review paper with the title Pharmacological Treatment of Attention Deficit Hyperactivity Disorder in Children and Adolescents Clinical Strategies. So our learning objectives and the outline for the talk today is that we'll first be going over a brief overview of how to diagnose ADHD and assess for ADHD. We'll be talking about some clinical strategies for first-line pharmacological treatment of ADHD. I'll talk about when we might consider alternative pharmacological treatments as well, and strategies to manage adverse effects. I'm also going to be talking about comorbid disorders in children and adolescents with ADHD. At the end of the talk, I have about 5 or 6 slides that goes over in more detail about comorbid disorders and how to treat them with kids with ADHD. I won't be getting to them today, but I just included them for your reference. So ADHD is a highly prevalent disorder. It's one of the most commonly diagnosed neurobehavioral disorders of childhood. In the United States, there's an estimated prevalence of 6.7 to 12%. So it's really quite high. ADHD, the energy to do anything, the focus to accomplish nothing. Children with ADHD exhibit developmentally inappropriate levels of inattention, hyperactivity, and impulsivity to the extent that it impairs them functionally, academically, in their family setting, occupational and social settings, and it also leads them to having an increased risk for substance abuse disorders later in life. In order to give a diagnosis of ADHD, you need to see at least 6 of the 9 symptoms of either inattentive or hyperactive impulsive symptoms for at least 6 months. In addition to that, these symptoms must lead to functional impairment in at least 2 settings. Another thing that I think is important to point out is that one thing that you want to do when assessing any child, but particularly ones with ADHD, it's very important to assess for comorbid disorders. One thing that they have found in the research is that when you have children with comorbid disorders along with ADHD, if you don't treat the comorbidity, they respond more poorly to the treatment of ADHD. Also, you'll want to assess if they have any developmental disorders or medical history that might lead you to feel that they might be predisposed or maybe mimic or exacerbate ADHD symptoms. Also, boys are typically more frequently diagnosed than girls. Usually, girls do not present with the stereotypical impulsive, hyperactive, rule-breaking, difficult conduct that you might see with some of the boys with ADHD, so they're less likely to be referred for evaluation. That being said, though, it's very important to assess when you're seeing girls if they do have any symptoms of inattentive type of ADHD, because it can be very, very impairing. And without treatment of their inattentive symptoms, it can lead to increased risks of mood disorders, depression, eating disorders, and it increases them for the likelihood of eventually having a substance abuse disorder later on down the line as well. As I mentioned, in order to be able to give a diagnosis of ADHD, you do have to have some sort of proof that it's occurring in more than one setting. So in our clinic, one of the things that we like to do is we like to give rating scales. We give them for both parents and teachers to fill out so that we can see how they're doing not only at home but also in the school setting. The 2 that we commonly use here are Conners, which is commercially available, as well as the Vanderbilt Assessment Scale, which is publicly available. There is very strong empirical support for the pharmacological treatment of ADHD as well as psychosocial interventions for the treatment of ADHD. Some of those psychosocial interventions include parent skills training, parent behavioral training, school behavioral interventions, which can be very helpful in adjunct to pharmacological treatment. And for those kids who are presenting with more moderate to severe ADHD symptoms, that's when you might consider not just doing pharmacotherapy, but also adding in some of those non-pharmacological interventions as well. Pharmacological treatment of ADHD has been found to be positively associated with improvement in academic achievement in school children, as well as improved health-related quality of life. Most long-term follow-up studies of stimulant treatment of ADHD in children and adolescents did not find an increased risk for substance use, abuse, or dependence by adulthood. And that's one thing that parents will oftentimes come in and state concerns about. You want to start my child on a stimulant, on an amphetamine. That sounds potentially scary. But in fact, what our data shows is that stimulant therapy in childhood is actually found to be protective. It's associated with a reduced risk for subsequent cigarette smoking, alcohol use, and substance use disorders compared to those patients who are left untreated. The MTA study is a very well-known study which has made a large impact on how we practice today. The National Institute of Mental Health, or NIMH, sponsored a very well-known collaborative called the Multi-Site Multimodal Treatment Study of Children with ADHD, or the MTA study for short. This study was a study of 579 children who had diagnosis of ADHD combined type, ages 7 to 9.9. And they were randomly assigned to 14 months of being in one of 4 groups. The first group was a group with very carefully monitored medication management. The second group was a group where they just received weekly intensive behavioral therapy with their parents in the school setting, individually. And the third one was a combination of the first and second, where they got both medication management as well as therapy. And then the fourth was standard community care at that time. And what they found was that there was a significant improvement in those kids who had either medication management alone or a combination of medication management as well as therapy, compared to those who had just had therapy or standard community care. They also did a couple of follow-up studies as well, a 3-year, a 5-year, and an 8-year follow-up study. And what they found was that there continued to be, with those kids who remained adherent to medication, they continued to show improvement over baseline compared to those who didn't receive treatment or didn't remain compliant with treatment. But they did show at the 8-year study follow-up that there was still a significant amount of impairment, even with those kids who were adherent to treatment, compared to those who didn't have any diagnosis of ADHD. Stimulants have over 50 years of history of clinical use for the treatment of ADHD. It's the most commonly prescribed psychotropic medication for children. In the year 2008, there's an estimated 2.8 million children who are receiving stimulant medications. So they're very well known to be used in the treatment, and they're considered to be first line in treating ADHD. They're also approved by the U.S. Food and Drug Administration for treatment of ADHD. Stimulants work by increasing levels of norepinephrine and dopamine in the prefrontal cortex, and in particular, methylphenidate blocks reuptake of dopamine in the synaptic cleft, and amphetamines increase norepinephrine and dopamine in the synaptic cleft by displacing them from presynaptic sites, and they also block their degradation. The response rate to stimulants is found to be very high. A review of the published methylphenidate and amphetamine double-blind crossover trials showed that 41% of the subjects enrolled in these studies responded equally to methylphenidate and to amphetamines. And there was 44% who responded either better to methylphenidates or better to amphetamines. So the initial response rate to stimulant treatment can be as high as 85%, as long as both classes of methylphenidate and amphetamines are performed. Both methylphenidate and amphetamines are available in either immediate release or once or twice daily long-acting formulations, and they have empirical support for both short-term efficacy and safety, as well as long-term effectiveness and tolerability. So it does take some decision on your part when you're trying to decide if you want to start your patients on long-acting versus short-acting. There's some benefits on both sides. With long-acting medications, if you only have to take them once a day, it makes sense that one is more convenient. Kids who don't have to go to the nurse's station in the middle of the day will have more confidentiality when they're taking the long-acting formulations, and it improves compliance because then you don't have to worry about whether or not they're making it to the nurse's office or whether or not they're remembering to take their early afternoon dose. And because it's long-acting, it can help them with their focus after school when they're needing to complete their homework. There are some times where you might want to consider short-acting medications. In particular, preschool children have been shown to have more adverse effects at higher doses of stimulants, and they have a somewhat unique adverse effect profile compared to older kids in that they have more irritability and proneness to crying when they're treated with stimulants. So you might want to consider short-acting medications for them because you can split the doses and you can dose them at lower doses with more precision and hopefully avoid some of their irritability and tearfulness. Also, if you have some kids who might come in saying, you know, I just can't eat my lunch when you have me on, you know, Concerta, that long-acting medication, and I want to gain weight, I want to grow taller, sometimes switching to an immediate release can be beneficial because you can let the children know, you know, make sure you have lunch, make sure you eat prior to going to the nurse's station, so that way the morning dose is pretty much out of their system and they no longer have any appetite suppression by the time they take their next dose. They've gotten some lunch into their system. And sometimes parents just prefer their children to be taking medications during school hours only and not while they're at home. Treatment can be initiated with either long-term formulations. You don't have to first start with an immediate release or short acting formulation and then switch to a long-acting. You will typically start at the lowest dose available, and then you'll titrate upward every 1 to 3 weeks, either until you've reached a maximum recommended dose or until the symptoms are adequately controlled with minimal adverse effects. I've included a number of tables here that are also in the paper that I'm presenting to you today, so I'm not going to cover all of it. I thought I would just pick out a few important pieces of information from them. One thing, I really think that there can be an art to prescribing stimulants if you're aware of some of the different properties that each of the medications have. So I was thinking about this, and for example, I had a child who came into the office who told me, you know what, Dr. Schreier, I really have a lot of problems focusing first thing in the morning and then right when I come in from recess. Whenever I have those big changes and I have to settle back into class, that's really hard for me to do. So in that case, I was thinking, well, knowing, if you look at the top two medications, Metadate CD and Ritalin LA, if you look at when they peak, when the serum levels peak, they have a biphasic peak. These two medications will peak early in the morning and they'll peak early in the afternoon. So I decided, okay, I'll pick one of these because then it'll help them when they're coming in from recess and in the early morning. But then I had another kid a few days later who came in and said, you know, mornings are tough, but one thing that's really tough for me is at the end of the day. I start to look at the clock, I get really fidgety. It's hard for me to not think that, okay, soon I get to go home. So in that child's case, I decided to use Focalin XR, which if you'll notice, the second peak is a little bit later in the day. So that was more helpful with the fidgeting that they had later in the day, and it also helped with the homework that he had to complete as well. And if you really want to get into the details of it, if you look at Metadate CD and Ritalin LA again, if you had a child coming in saying, you know, the mornings are difficult, but it's really the early afternoon that's tough for me. If you look, 30% is immediate release in Metadate CD, and 70% is the extended release. So you'll have greater coverage in the afternoon, so you might pick Metadate CD over Ritalin LA if it seems like early afternoon is what's really tricky for them. Another thing to point out too is that Focalin is slightly different from the other methylphenidate formulations in that it's just dextro methylphenidate. So if you'll notice, the maximum dose is 30 compared to about double for the other medications because it has greater efficacy. Also, Daytrana is a patch, and that is, there are a couple of things I just wanted to mention with the patch. Patch forms are more bioavailable because they administer the medication transdermally, and there's no first pass metabolism. And one thing that I like to tell parents is that there is a difference in the amount of drug availability. It's more bioavailable on the hip than on the scapula, which are two places that will oftentimes tell parents that they can put the patch on. Also, in hot climates, there's greater bioavailability as well. So here in Arizona, we'd want to let parents know that. So if you have a parent coming in saying, you know, the patch was working great for a while, and now for some reason it's just not working as well, it's good to ask, are you switching where you're putting it on their body? And are they playing outside more or less compared to when we first started it? Another point of difference between methylphenidate and amphetamines is that methylphenidate is considered to be somewhat less stimulating than amphetamines, and the belief is that it's because the rate of occupying of the dopamine transporters may be slower, so therefore less reinforcing and less stimulating. There also has been research indicating that they have somewhat fewer side effects than amphetamines, but that amphetamines are slightly more effective. Overall, though, they do have a very similar side effect profile. Also, you may find that your patients gain tolerance over the first couple of years, and they may require an increased dose or dose adjustment after about the first 6 or 7 months. So here is a table that I included for the amphetamine formulations. A couple of things just to point out that are different here. If you notice the top 3, Adderall, Dexedrine, and Dextrostat, they're all approved for ages 3 years and older, versus all of the other stimulants are approved for 6 years and older. Another thing that I didn't mention earlier, all of those medications that indicate that they have delayed release beads or just beads in general, those can be split and sprinkled into food for those children who have problems swallowing pills or capsules. Vyvanse is also a unique medication on this compared to the other medications on this table. Vyvanse is actually an amphetamine prodrug. It's lisdexamphetamine. And essentially, it's required to enter into the gut prior to taking effect, because in the gut is where the lysine is cleaved and the D-amphetamine is released. So it's considered to be less likable because it has a longer onset of action because you have to wait for it to be digested. But it is still a Schedule II drug. In our clinical practice, we recommend visits or else at least telephone contact at least every 1 to 2 weeks when we're first starting a patient on medication. Usually that's during the first 1 to 2 months. And once you do reach an optimal dose, then you can typically follow up anywhere from every 1 to 3 months. And at that point, just assess if they're having any adverse effects, what their progress is, and if they're needing any dose adjustments at that time. Each time that they come in, you'll also want to assess their weight, their height, blood pressure, and their heart rate. Another thing that oftentimes clinicians will do is they'll start in one class, say methylphenidate, and if one medication of methylphenidate in the methylphenidate class doesn't work, then they'll typically switch within the same class. Also, oftentimes we'll go above the FDA max as long as our patients are still showing improvement and as long as they're not having significant adverse effects. And then once we've tried 1 or 2 within one class, then we'll typically switch, say, to amphetamines to the other class. Adverse effects are usually more severe when first initiating a medication trial, and they tend to abate somewhat over time. The most common complaints that patients have when they come in are decreased appetite and weight, irritability, insomnia, and headaches. In general, as I mentioned before, methylphenidate tends to have less side effects, but a similar side effect profile compared to amphetamines. And some of the less common adverse effects are tics, emotional lability, irritability, and increased heart rate. Some parents also have came in, and children for that matter, reporting that they're really concerned because they heard that stimulants can stunt their growth. There are some mixed results in the data regarding how stimulants affect growth. In the MTA study, they showed that there was a decrease in growth rate without evidence of growth rebound at a 3-year follow-up. A review of 29 studies reported about 1 centimeter a year of height deficit during the first 3 years of treatment. Farrow et al. Did a study where they showed that there was slightly less growth than expected after 3 to 6 months of treatment, but then in a later review by Farrow et al., they concluded that it was just a transient delay in growth, which could be caught up later, either on or off medications. And then there was a more recent study, which was a 10-year prospective study, which didn't find any association between deficits in growth outcomes and stimulant treatment. So there is a little bit of mixed results there. Now, there was some concern back in 2006, a bit of a controversy with the FDA. At that time, the FDA had requested some assistance from their advisory panel. There had been some data that came out regarding sudden death in individuals who were taking stimulants. So they wanted to get some input from their advisory panel as to where they should go with research into trying to decide whether or not they wanted to put a black box warning on. The advisory panel then came back telling them, we really strongly feel that you should put a black box warning on the medication. And usually the FDA typically accepts what their advisory panels suggest. But in this case, they felt that they really wanted to get more data prior to doing that, especially in light of the fact that they had seen quite a strong impact on prescribing in the community with antidepressants when a black box warning for suicidality was put on antidepressant medications. So what they did was they had a review of the adverse events reporting system data over the years 1992 to 2004. And what they found was that the base rate of sudden death in children treated for ADHD was actually below the sudden rate death in the general population. So because of this, they decided not to put a black box warning, but they do have in the pamphlet insert that that children and adolescents with known serious cardiac abnormalities or heart rhythm abnormalities should likely not be on the medication. And I also added a little picture on the bottom as well. There's also in the pamphlet insert a warning for potential abuse of stimulants as well. So when you're considering putting your patients on a stimulant, it's very important to ask about their own personal cardiac history, if they've had chest pain, dizziness, syncope, palpitations. You'll also want to find out if they have a family history of individuals with early heart attacks, sudden death, or arrhythmias, and you'll want to take their blood pressure and pulse. While an EKG is not mandatory, if you're concerned, it is a good idea to get one. It isn't considered mandatory. But in fact, if you are concerned, you might even want to just tell your patients that it would be best if they have a known history of either family or personal cardiac history, and that they might want to get themselves cleared by a cardiologist prior to you starting them on a stimulant. There are some ways to manage stimulant adverse effects. In our clinic, we'll oftentimes tell parents to either give their medication after they've had breakfast or with the meal so that appetite suppression hasn't yet started to occur. We'll tell them to have very large breakfasts, very large dinners, and that they can have as many snacks as they want throughout the day, as well as after dinner nutritious snacks at night to prevent weight loss. Also, we recommend that parents don't give their immediate release doses to their kids in the evening, and we usually don't recommend them to take it after 4 p.m. in the afternoon. Now, if adequate trials of both stimulants, amphetamines and methylphenidate have been tried and failed, or if your patients are having too many adverse effects from stimulants, you may want to consider alternative agents. So what I mean by alternative agents are non-stimulant medications. Now, they aren't considered first-line agents because they have a much less robust response compared to stimulants. In a meta-analysis report of double-blind placebo-controlled ADHD treatment trials, they indicated that the effect sizes for non-stimulant medications were anywhere from 0.6 to 0.7, versus with stimulant studies, the effect size was as high as 0.95. So quite a bit difference there. There are times, though, that being said, when one might consider starting with an alternative non-stimulant medication. Comorbid tics are one of the cases where you might consider starting with an alpha-2 agonist, since we know stimulants can exacerbate tics, and that's one way of alpha-2 agonists are a way to treat tics. Also, those kids with anxiety disorders, you might want to consider, or depressive disorders, you may want to consider bupropion or Strattera, which would kill two birds with one stone there. And if you have substance abusers, it is sometimes worrisome to be prescribing a stimulant if you know that your kid is a substance abuser, since there is a likelihood as well of diversion of the medication. And sometimes parents just don't want their children on stimulants. So the alternative agents that I'll talk about today are atomoxetine, guanfacine, clonidine, bupropion, and modafinil. And if you look over to the right here at this cartoon, it looks like these teenagers figured out their own non-stimulant alternative agent. One kid's playing a video game and the other kid says, "You played for 6 hours straight. I think you found the cure for ADHD." I don't know if I'd necessarily recommend that, but here's an adult version of an alternative agent, a non-stimulant. The boss is telling his employee, "The cannon will go off every 20 minutes just to make sure you're paying attention." That could be a little disruptive, though. So our first alternative treatment that we can consider is atomoxetine, otherwise known as Strattera. It is approved by the FDA for treatment of ADHD in children, adolescents, and adults. It is a selective presynaptic norepinephrine reuptake inhibitor. It acts to increase levels of norepinephrine and dopamine in the prefrontal cortex. For those kids that you're starting who are under 70 kilograms of weight, you'd want to start them at a dose of 0.5 milligrams per kilogram a day with a target dose of 1.2 to 1.8 mg per kg per day, titrating up every 3 to 5 days. For those who are over 70 kilograms, you'd start at 40 milligrams a day. In 3 to 5 days, titrate up to 80, and then your maximum dose would be 100 milligrams per day. Going above doses of 1.8, research has shown doesn't necessarily help with ADHD symptoms, and in fact typically leads just to more side effects. On the other hand, there was a study treating ADHD kids with comorbid ODD, or oppositional defiant disorder, and they found that they really had to push doses up to 1.8 in order to see resolution of both ADHD and ODD symptoms. That 1.2 just didn't quite cut it for them. Now, daytime sedation is an issue with atomoxetine. So typically for the first week, we start the medication at bedtime. And then after the first week, the dose can be either given in the morning or in the evening, or you can also split doses if you want to avoid some of the sedation and GI side effects that some people complain of. You also will be seeing symptom improvement after about a month, but remission of symptoms usually doesn't happen until about 3 months later. So you will want to tell your patients and their parents to have some patience when they're starting atomoxetine, because it does take some time prior to having full remission of their symptoms. Another thing to know is that atomoxetine is a medication that can be abruptly discontinued. You don't need to taper off of it. Another thing to keep in mind is that if you have a patient who's already on Prozac or Paxil, this is a medication that is metabolized by cytochrome P450 2D6. So if you are giving them together, you'd want to start atomoxetine at a lower dose, typically 0.5 milligrams per kilogram a day for the first month, and titrate quite slowly and cautiously. And typically the target dose would only be 1.2 rather than 1.8 if they're on Prozac and Paxil or Paxil. Atomoxetine response is reported to be less robust than stimulants. In that meta-analysis that I previously mentioned, the effect size for atomoxetine was about 0.7 versus for stimulants it was as high as 0.95. There is evidence of efficacy, though, in children with comorbid oppositional defiance disorder, as I'd mentioned, children with comorbid pervasive developmental disease, and anxiety and mood disorders. Atomoxetine is usually very well tolerated, and youth show good long-term adherence to the medication. There are a couple of things, though, that I do like to warn patients about when starting atomoxetine. It does have a black box warning similar to antidepressants, that it's associated with suicidal ideation. So that's something that you are required to let parents know about. It's also been shown to lead to very rare hepatic injury, but it's also good to let parents know about that. And on the left-hand side are some of the more common adverse effects that your patients might have. Also, because of the noradrenergic effects of atomoxetine, children can experience an increase in heart rate and blood pressure. So similar to stimulants, you may want to avoid using atomoxetine in those children who have known serious cardiac structural abnormalities. One option, if you have patients who are only partial responders to atomoxetine, is to add a small amount of stimulant along with the atomoxetine, and that tends to help with ADHD symptoms. But they have shown, though, that when you do combine the two, there is a higher frequency of adverse effects. So that's something you'd want to do with some amount of caution. So our next picture here is a puzzle, which I'm not sure if you can figure out, but find the kitten who has ADD, and it's actually ADHD, but find the kitten who has ADHD, and paying attention, oh, there's the kitten looking at the ball. I think it's that one. Okay, so alpha-2 adrenergic agonists are the next of the alternative non-stimulant medications I wanted to talk about. Immediate-release clonidine and guanfacine are not approved by the FDA for use in children and adolescents with ADHD, but they have a very long history of off-label use. They are antihypertensive agents. They inhibit norepinephrine release and downregulate the noradrenergic system. Clonidine has relatively high affinity for all three alpha-2 adrenoreceptors, alpha-2A, 2B, and 2C, versus guanfacine is selective alpha-2A adrenoreceptor agonist. And because of that, guanfacine is less sedating in general than clonidine. Extended release formulations have also been developed, and these are approved by the FDA for treatment, either monotherapy or adjunctive treatment to stimulants for children and adolescents with ADHD. So in the meta-analysis that I had mentioned previously, they had shown that the effect size for clonidine was 0.58 compared to 0.82 for stimulants. So again, this is one of the reasons why alpha-2 agonists aren't considered first-line stimulants, are much more effective overall. But it is something to consider, though, if you have patients who are having adverse effects from stimulants. It still is a pretty good effect that you'll have with clonidine or guanfacine. With immediate release clonidine, you would start with a dose of 0.25 to 0.5, and you'll typically start at night because the most common adverse effects are sedation, and then you can titrate up every 3 to 7 days in increments of 0.5 milligrams. You can titrate up to a total daily dose of 0.4 milligrams. Immediately release guanfacine can be started at either 0.25 to 0.5 milligrams, also at night. And you can titrate up every 3 to 7 days in increments of 0.5 milligrams, with the first additional morning dose of 0.5, and then followed by adding a 0.5 dose of an after-school dose. And you can titrate up to a total daily dose of 4 milligrams. As I mentioned, extended release formulations have been developed and are approved by the FDA for treatment of ADHD in children and adolescents. Clonidine, you'd want to start at 0.1 milligrams at bedtime, and then you can increase weekly by 0.1 milligrams up to a daily dose of 0.4. And this would be given twice daily with either an equal or greater dose at bedtime. And guanfacine can be started in the morning, 1 milligram, and it can be titrated weekly to a maximum of 4 milligrams. And it might take, though, 2 to 3 weeks to see a response, so that's a good thing to let parents know about as well. Somnolence and fatigue, as I mentioned, are the most common adverse effects, especially during early titration. And one of the ways around that is to go more slowly with your titration up, or else back off on the dose if they're complaining of too much fatigue. Again, guanfacine is considered to be less sedating than clonidine, so you might want to consider that if you're treating mostly symptoms during the day. Another very important thing to mention to patients and to their parents is that it's very important to take alpha-2, these medications regularly, because if they're suddenly stopped, you can have withdrawal hypertension, and we would certainly want to prevent a hypertensive crisis in our patients. Also, orthostatic hypotension is a adverse effect, especially in the beginning when kids are first getting used to the medication. And aside from that, the most common, as I mentioned, side effects are somnolence and fatigue. ADHD. We think more things before breakfast than most people think all day. Lucky them. Okay, so bupropion can be considered if stimulants and atomoxetine trials fail, or if you're having too many adverse effects from stimulants. As well, you can also consider starting with bupropion if you have patients with comorbid substance abuse disorders or mood disorders. Bupropion is an atypical antidepressant, and it inhibits norepinephrine and dopamine reuptake. In a multi-site placebo-controlled trial, they using dosages between 3 and 6 milligrams per kilogram a day. They did show that there was some improvement in hyperactivity, conduct problems on both parent and teacher ratings, but it was a smaller effect size when compared to stimulant medications in that study. It's been shown to be effective in those youth who are have comorbid substance abuse, mood disorders, and depressive disorders. There was a study, though, that did show, at least in this study, that that there was some improvement in just the parent ADHD rating scales, but not so in the teacher ADHD rating scales when that population was treated with bupropion. Bupropion is usually a very well-tolerated medication. One thing that you will want to ask your patients prior to starting them on it is whether or not they have a history of seizures, and you'll also want to assess for any comorbid eating disorders, which also could lead to seizures since bupropion does lower the seizure threshold. So this next cartoon, this poor kid is giving his mom his report card, and she's saying, ADD. Are these your grades or your diagnosis? Another, and the last on the list of alternative medications that I was going to talk about today is modafinil. It's not a medication that's typically prescribed in the community for treatment of ADHD, but there has been some promising research at this point. The FDA though hasn't yet approved it for treatment of ADHD, and at this point it's just approved for the treatment of narcolepsy. Its mechanism of action is unclear, but it appears to have effects on dopamine and norepinephrine. So again, there has been some research supporting the efficacy of modafinil. One of the reasons that the FDA back in, I think, 2006 decided not to approve modafinil, though, was because there were a couple of cases, I think they had about 900 to 1,000 total number of kids, and there were a couple of cases where they had some very serious rashes that they thought might be Stevens-Johnson. But dosages, when you are considering modafinil, range from 170 to 425 milligrams a day. And there was a study, it was a 6-week placebo-controlled study with kids ages 7 to 14 with ADHD, and they showed a response rate of 78% compared to 0% with the placebo. Potential adverse effects are insomnia, headache, decreased appetite, and again, some rare but serious cases of skin rashes. Adverse effects in general were mild, and again, this medication is not approved for children with ADHD by the FDA, and it's not approved for children under 17 years old. So these are just the extra slides that I said I included for your perusal if you have any children who have comorbid disorders with ADHD. I've found personally that those are the most difficult to treat. So sometimes it's helpful to have a few tips. ODD is the most common, though, to happen and occur in conjunction with ADHD. So just a really quick pop quiz. Oh wait, actually, let me summarize. So in summary, the first-line treatment of ADHD is stimulant medications. There's a very high response rate to stimulants for those children with ADHD. But despite that, there are some situations where you might want to consider alternative agents, as we had discussed, and that comorbid disorders in children with ADHD can be challenging to treat, but with thoughtful consideration, there are options available. So just a really quick pop quiz. My son is 3 months old, and I thought no time like the present to expose him to some of the academic life. So I gave him my speech, my talk that I did today, and clearly he started to daydream. So he has ADHD, right? Right? No, because it has to be in more than one setting. So we'll see how he does in daycare. Yeah. Plus he's a little young. I guess I'll wait a few months before I give the lecture again. We'll see. But thank you very much.